practice that. So you put the patient on the table, you get them to AP, you take them this way, you take them that way, you talk them this way, to make sure you can see all the bits of bone you want to see in the direction you want to see. Moreover, you set your AP on the intensifier, so that image that you see on the table in that position matches the preoperative plan up there. Otherwise, you'll get problems with how you change it. So if we look at this, and Scott was talking about doing your pubic osteotomy. So you come down with dissection here, you've done your little osteotomy off the anterior celiac spine, you've retracted that off with the ilioligamal ligament, sartorius, you come in laterally, protect your nerve. Up here, you come down across here, you feel the inferior spine, which is the straight head, the rectus femoris attachment, reflected heads down here, you can see that in dissection. You come down, you go down this side of it, you come into this little groove here, and you just keep going along there, lifting up there, and you'll get into the iliopsoas bursa, which is coming across here. Hit the iliopsoas bursa, you know exactly where you are. You can dissect that, but that'll guide you down the medial aspect of the capsule to be able to get to this point. When you get to that, you put your retractor along the pubic rim here, like this, on X-ray control. You can see that point, see that's a good point. And then put it in the pubic symphysis like that, lift it up as a retractor. Then you know, and you can feel this bump here. With your finger, you can feel that bump intraoperatively. You see, that's the iliopectineal eminence here. As long as my osteotomy is medial to that, I will always be outside the joint. Can you see that? As long as I'm medial to that, I'll be outside the joint. See, that's very important. So you can start your osteotomy there and then go medial to that, and you angle that down in that direction. Right? As Scott was saying, that angulation is important because you want to go rotate that fragment, but you want stability as well with that fragment. Do that cut, that's the first cut. And remember that your retractors are going around the pubic ramus like this. Yep. So the reason for that is because the arbitrator nerve and vessel are coming just there. Yep. If you really want to be safe, you go really far medial. If you go too far medial, osteotomy rule 2, translation. Right? Big amount of translation, you get non-union. It can be prominent here, it can affect the iliopsoas function, you get prominent iliopsoas afterwards, that's difficult to come back from. So you want to be as close to the acetabulum as possible. The closer you are, the better rotation, but beware of the obturator nerve here. So you put the leg up in a slightly flexed position like this, you slightly adduct the leg like this to release, so you don't have too much traction in the femoral nerve and artery when you're using this retractor. This is underneath iliopsoas. The femoral vessels are coming across on the top here, like that. So you're lifting them up. So you lift the leg up like this, adduct it so that's nice and loose, all right? And then you put your retractors around here, subperiosteal, and do your pubic osteotomy. You then need to find this part of the issue, right? Infracotyloid notch, which is down here. To do that, you find your iliopsoas, you go into the bursa, and you open the bursa up and you just track iliopsoas all the way down. You pull the capsule towards you, keep the capsule closed at this stage, don't open it. You pull the capsule towards you and go down this side. You take your scissors and you go parallel to the pubic ramus. Take your curved scissors and do that. You'll automatically hit the ischium underneath that. Remember, obturator internus is coming along here. Transverse fiber is doing that. So you can open that up with your scissors. The capsule's here. You're on the capsule. Stay on the capsule. Go down. Iliopsoas is coming here. Go down. Hit the ischium. If you look down there, you'll see some transverse fibers. That's going to be your obturator internus going across there. You want to be just above that. You want to go onto the bone and feel you coming up. You can feel this. It goes up. As you put your osteotome like this, you feel the inferior cotyloid notch. That's what you want to select because the vessel is coming across here. The inferior blood supply coming through here. The obturator vessel is coming in here into the acetabulum. Up onto that. That's where issue osteotomy is going to be. You're taking a curved osteotome. To do this, the Guns osteotome. One of these ones, or either one of these ones, or that one that was shown on the X-rays, which is saying pointed, will come in here, and with the narrow one. And this is a partial osteotomy. So you can feel this like that. The starting point is going to be with the handle almost vertical. And as you do the osteotomy, your hand will drift inferiorly like this, so you go up underneath the acetabulum towards the lesser spine. You still see that? Towards the lesser spine. So you will rotate your X-ray picture, your machine will go this direction, right? And then come back towards the patient. So what you're then seeing is that spine in profile. And your osteotomy, you want to be coming up towards the spine like that. You see that? That's the direction of the osteotomy. This osteotome, you start off, what you do is, see it's notched. The idea behind that is I can sit that notch on the obturator, on that insert. I can go into the operator foramen, go down this way, and feel this. So with my fingers, I'll get the mental picture of how big this piece of bone is. I sit between the two. And I hook it on there, and I start my osteotomy there. And I check that I'm going in the right direction towards the spine. I do about 10-15 millimeters this way. I bring it back out, wiggle it back out, stay in the gap, turn it slightly towards the outside, go in again. Slightly towards the outside, go in again. At this point in time, we start to go to the back here, at hip, you want to externally rotate and abduct to take the sciatic nerve away from your osteotome. And you'll find that if you try and push your osteotome outside the bone down here, it stops. That's because of the attachment of the hamstring, right? So you know that's far enough. This bone down here, if you'll notice, if you look at it, is triangular in shape. So your osteotome is to go here, here, and here in a triangular shape. As you work on that osteotome, keep working it, bring it out, keep working it, bring it out. Because this makes it easy. This is the commonest sticking point for this rotation, this osteotomy. If you're struggling to get this unhitched and rotated, that's where it's sticking. So really work on this osteotomy to make sure you've got the complete osteotomy halfway through towards the ischial spine. Okay? Then we'll be in this position. So you do your iliac osteotomy, which starts, your cut of the anterior celiac spine is here, just at the edge of that cut will be where you want to start this. And at this point, on the inner table here, about 1 centimeter above the brim, right? You have a brim, your retractor will go in here and do that. At the brim there, 1 centimeter away, you'll put a mark. And you saw in the picture, it'll blur, it's quite easy to do a mark there, something to aim at. Okay? There. And then your osteotome will go perpendicular to the ground. From here, straight down. Okay? Towards that point. And you notice that my acetabulum is at that angle. That's the orientation of my acetabulum. So that's going to be the orientation of my osteotome as well. Not straight, because if I'm doing straight down, I'm approaching the posterior edge of the posterior wall. So I want to curve that a bit like that. Alright? So that's the orientation. That's the orientation of my osteotome as well. Going straight down towards that point. When you hit that point, you want to do 120-degree that one direction. So you take your osteotome, take a 1 centimeter osteotome, right like that. That's about 1 centimeter from the brim, put it in the hole, and rotate 120 degrees this direction. Okay? And then I'm going to cut just the interior cortex. So I'm going to start going down the interior cortex like this, and this is what you see. You don't see very much, interior cortex. Then take the image intensifier, and I'm going to rotate it in again, so we can see the ischial spine. You can see the ischial spine and the acetabulum. You want to be going directly between the two. You want to bisect the posterior wall going down towards the quadrilateral plate. I take the one osteotome and I just go just that cortex down towards where I think my other osteotomy ended, or as Scott was saying, where you've got the osteotome still in the osteotomy site, you go down towards that. The other sticking point he said was this angle here. So if I take an osteotome, I'll take this one, and I put it in that hole there. If I put this osteotome perpendicular to the face of this bone, you can try it, perpendicular, it will come out exactly at the right spot posteriorly. As long as the osteotome is not doing that, or doing that, but I'm absolutely perpendicular to that face of the pelvic bone, it will come out in the right spot posteriorly. And you know you've got that cut, and the angle cut is done. Then as you put your chance spin here, and you put your lumbar spread in here, it will split down towards your other cut. The posterior will also crack down that same column. And then you take your final osteotome, which is this one. It's angled at a particular angle. So if I put it on the pelvic brim, put the angle on the pelvic brim, right? Angle not more than 50 degrees, I will then cut towards that inferior cut, or complete that little corner down there. You take your X-ray machine and you do 45 degrees, slight internal rotation, you'll get that perfect picture, and you can actually see this osteotome in perfect profile to connect the cut coming down and your ischial cut in a little corner, right? And you cut then towards the back. And in doing that, you put a lumbar spreader in this corner here, spread it a bit more, put it under tension, it'll crack. And or suddenly it will free up. And you immobilize that fragment to make sure you're nicely free, put it back in the correct position. And then in terms of doing your correction, you've got your shank screw in here, as Scott was saying, and you've got to correct. So this is an oblique plane, right? So if I correct like that, more of my anterior wall is going to cover it, anterior impingement. So I'm going to correct it this direction, I'm going to correct it the version, that direction, all right? And then I'm going to medialize it. So you've got at least 3 maneuvers to correct the position. Then pin it, and then check the intensify, you've got the correction. Okay. Want to add anything to that?
Yeah, really well said.
So you try those cuts, pubic cut, medial to eminence, ischial cut, partial cut, heading up towards the lesser spine, and then these 3 cuts straight down towards your angle cut, 1 centimeter from the brim, turn 120 degrees, single cut down the cortex towards the quadrilateral plate, and then connect up those 2 osteotomies. Shan't screw in, and then you need to play with it to do your correction.
Which cuts do you like to use a saw for versus an osteotome?
So I use a saw for the first cut of the issue, and I use an osteotome, and I use the osteotome for all the rest. You can use a jiggly saw under the pubic radius if you can, so it's less controlled in terms of the angle you do it. I think that's quite important. So once I've done that cut, I will put a retractor in there as well. That helps lift it up so it doesn't hitch when you try to do your correction. Yeah. Which cuts I do? So I do my ischial cut first, and pubic cut, and those cuts. Scott is a very good technique because especially when you're starting out, you do pubic cut, then do ischial cut, leave your osteotome in there, and then complete the cuts here. It all depends a little bit on the approach, because obviously with this osteotome and this retractor in here, it gets quite tight. It depends on your approach or what approach you're using.
Yeah, I don't have a retractor here with the osteotome. Let's do this first, but then there's
Leave that
retractor. But certainly, I think the normal technique is to do the ischial cut first, because just like we like to have our dessert after eating vegetables, you do the ischial cut, and it's the most difficult one. So with that concept in mind, it's a good way to do it. I think once you have experience, it's certainly fine, but it is nice to be able to visualize that osteotome in there when you're doing the posterior column and have both of those to correct that corner loose for me, and it doesn't require going back in there and re-cutting that one if you do it in that way.
How distal you go with the approach?
That depends on the size of the patient as far as if you're talking about the incision. So if the patient is larger, doing the more traditional Smith-Peterson is helpful. And I think also starting out, doing a bigger approach is something that's excusable, and you're not going to cause any problems by doing that. In fact, you're less likely to cause problems if you have a bigger incision in this type of surgery. So it's difficult, and don't try to be minimizing your incision on the first few times you do it.
There's no study looking at the improved outcomes from doing a minimally invasive procedure. You need to see what you're doing with this osteotome, because this is looking at preserving a joint for as far as possible the lifetime of the patient for as long as possible. So you need to get this operation right. How big an incision you need is the big you need. Somebody asked Professor Guntz while he was doing an operation live surgery, how big an incision? It depends on how big the patient is. The bigger the patient, the bigger the incision. You need to see. You need to be comfortable doing the osteotomy. Ultimate end point of your approach is to do a perfect osteotomy.
One other comment, this osteotome here is a little different than the ones I showed in the pictures. When you're cutting hard bone with these osteotomes, some of the energy is going right out of this sharp corner right here, and those curved ones really help to transmit that energy into the end of the osteotome. So these ones, I guess, I don't know why they're still around, but they're just a little bit of an older style. Do you have a preference of using these over the other ones for anything?
No, I've got the newest set. These come with the old set. I've got the newest set and the old set.
The ones with that sweeping curve.
They've got a nice narrow curve. It's also hooked like this, but it's a complete blade. It doesn't have a shoulder on it. The shoulder can get stuck in the osteotomy site. So you only have this kind of saw to do your saw cuts, unfortunately, but that's okay. You should be able to manage that. Mark them all out. Think about what would be worthwhile doing is perhaps taking a marking pen or something and just marking out your cuts so you understand what you're trying to achieve, and then going in and cutting it. And we'll,
With the pubic cut, when you position from how you position that direction?
So the cup you want to change like that and like that. So you want to in this direction. So like that. You're going this direction. So that the pubic radius is in that direction. You want to be perpendicular to that. That, not so much, because the pubic radius is already at that angle, you're going almost perpendicular to that, you can just incline it this way. If anything, do that. What you don't want to do is that. If anything, that way, but certainly this way. Okay.
And then one other, I don't know what your comment is on this, but sometimes it's, when you're cutting this one straight down here, it's easy maybe to be like this a little bit, but you really need to be a little bit rotated this way, because when that adducts, you want those surfaces to slide on each other. If it's cut this way, when it adducts, it's going to pull apart from it. So having it slanted with this lateral edge, a little inferior to the other edge is important. It's basically perpendicular to the slope exactly.
So, time for bone cut.
Bone cuts will come around and help you and answer any questions you want to critique your results.
You have 15 minutes to cut.
Okay. So go. To the table.
But I prefer that you go. We are very limited in time, so look and do by yourself.
So I start off by doing a little bit of preosteal so cortical like a judo pedaling, right? Until I get to the right spot. And that's because it lifts up the bone cuts like that, you're more likely to get good bone healing, right? And then you take your osteotome perpendicular to that, with a slight angle. And in that direction. Remember the nerve coming underneath here. Yeah, just that side, medial to the back. Then what you, when in that position, take the protection on you and make sure that is mobile. You can see it doing that, right? Because you want to know that at least for this cut, completely through, it's mobile, it's not going to hit there. You're not probably worrying about this cut or this cut down here. So I do that to make sure it is nicely apart. Look like you want to come down here. And you find, I can do this, I can feel it, without looking I can do this, I can feel it coming up against the cockroach notch. That's where I want to start off there. I'll hook it in this operating foramen, like that. And then I'm going to start in this position. This is perpendicular to the bone. I'm doing this. Angle it up towards the spine.
Maybe it's better.
Aim towards the spine. Hold it. So you are looking to go up there. Up there. You see it's triangular bones. So you want to come out, get it in there, so lateral side. Keep doing this. Keep wiggling like this, like it out, like that, so you can feel.
So now at this stage, how you turn the beam of the
So my beam goes to straight AP, it goes over there about 25 to 30 degrees, sometimes 40 degrees, depending on how much bowel gas you've got. The bowel gas will influence what you can see, 20 degrees. Because the machine's gone that way, you have to then bring the machine back towards central nervous pubic symphysis. So out there and back. And that gives you a perfect picture. What you're doing, about the width of this blade, if you go in too far, you catch your shoulder there, it can be quite difficult to get it out. So whenever I'm going in there, I'll wiggle around. Right, this maneuver, right? Your hand.
רגע, תסמן...
About 10-15 millimeters.
Just a moment.
to the newer one available. Right? This is slightly better because this is the other one. So they are
right and
right
left.
and left. Right. This is slightly better because you can. Corner down here because I know that's going to be much really good. Just go slowly. The thing is, this is very hard bone. It's very hard bone. And because you're below the collar, you cannot crack into it. So I'll leave it like that just to get a sticking point. Now we can put this on here for a second. Now we need to mark about a centimeter from the brim. So go straight down here, about a centimeter from the brim here. The mark. The perforating vessel from your internal vessels coming into the ileum, the bone vessel comes into the ileum over here. Sometimes you get a lot of bleeding here. If it's coming through bleeding through the bone, you can take bone ore. You just crack it into the foramen to stop the bleeding, otherwise you can bone wells. The saw cut is going to be, will be, I mean, this piece has come off, so we've done our osteotomy here. Then osteotomy here, how big a piece do you do? Enough piece to fit it out to the skin, right? So that'll then come this way, right? Our starting point is going to be down here. It's not directly vertically like this, and sometimes it's quite sharp into the bone. Normally you cut it like this first to get a starting point. That's the angle I'm going to use. And straight down to the point. Retract it in here, retract it down here. Look at a small window here.
You do first here, the mark centimeter to the brim, and then you go to it from the bottom of the ear.
So guys traditionally taught, and what I've always done is do put a mark there, do this cut. Joel Matt and the guys in the States put a mark there, do that cut first. This is the easiest cut and connect it there. Okay? Then take an osteotome and start at that point. I do a 120 degree cut. So I'll start here and I think, well, that's 180 degrees, that's 90 degrees. So about like that's going to be my cut, about 120 degrees. I'll put my osteotome like that. Then I'm going to take an x-ray. Again in that position. Right? What I'm looking at then is that picture. And I can see that I'm halfway between the sciatic notch and the acetabulum. And I want to go down that close to so a little bit towards it. Rotate a little bit like that. Follow this all the way down. And I can see that on the I'm not concerned about where this has gone entirely because I only cut the medial cortex. So I haven't gone all the way through. So I know that I can't have been less heavy. And I check that I make sure that's alright. Then I know that if I then is perpendicular to this bone, perpendicular like that, come out. And you start to open up here, so I'm coming back here. Let's work at this a bit. Come out the back here. Keep working at it. We get stuck. Just get stuck, you can't get it out. Just take another one. Then that one comes out again. you see it start to open up here? Then I can put my shank screw in here, right? Put a downward thread in there, put under tension, continue to work this part. Extend down the back here. Now that's cracked all the way down to this bone. Then the next thing you do is to then this portion. I go there, and there, and connect this part. This is often the sticking point. So this is what happens in reality. You've got this part, this is what you see. Now this thread here, now this thread here. Because you do the corner here. Now you can see here. So now you need to connect this. So this is where you take your X-ray machine, you do that, and you can connect this one again. Dry bones and cracks. But then you're back in this position. Okay? We'll put it back in that position. And then you take your cap and you're going to do that with it. Right? We're going to medialize it. And we'll rotate it in like that. Show the screws going from here up towards the corner there. Like that. Yeah. Get quiet. Get quiet. Just above, make a cut through the direct head, reflecting it through into your spine. The drawback is you start it like that, so you've got a hard cortex, then take a shank screw and just screw it in, so it goes down the bottom here. I want to aim on this corner over here, I want to leave enough bone here, so that at least visual fixation.
more challenging part of it.
So that you don't need live, you're going to get this effect. Yeah? You get like a salted. Salted channel, so it won't be just over the way. You have to make sure that you actually this piece of bones up against here, and then you know you've medialized enough. This maneuver first, so now you've got your message covered. And then you're going to have to medialize it. Make it this bone back here. This piece is up against the bone, it's like that, good selection. So you have a medialized, this will tell you down here somewhere. It must be up against the bone here, so this is one. You'll see this point here, so this is like that. How do you know this is removed? Look at the independent spine move, to the teardrop. The teardrop was moved, up towards the pubis. Right? If the teardrop hasn't moved, you haven't medialized. Check that. That's it. That maneuver, and medialization. In that position. So trim this top on the bone off here, put it in here, just stick it out. Right? And open hip joint up. So lots of this, so dead cut like me. Look inside my hip joint and I can actually see the rotation. And then put the hip joint, take this pin out, the hip joint in range of motion. I can do here, test for intention. Or hip joint open, I can do osteochondroplastics, or I can repair my leg. That maneuver, that maneuver. Let's make sure there's no contact now. That will just screw anymore. But I have it up, it's really unstable, you can just screw it. One shake, better come on. It doesn't fit the patient. I've had in my career, I had to go and refix one of these. Had column fracture like this before. Had 3 non-unions in my career, and now I've gone back and replaced only 2 of them. One's been amputated. 2 non-unions.
Where was the new one?
Issue. People non-union tend not to be a problem. But I do osteograft of the pelvis. Issue one can be. Then the cause is instability of the pelvic ring. I get posterior pain, the SI joint instability. I've gone down to doing the posterior column plating. Let's just use screws. Screws are much tighter. So in the screws, I can take this bone and I can rotate the whole patient like holding that fragment. That's how strong it is. If you have instability, because you have quite a fixation, it's fine. We'll recon plate here. It's fine. I always put it back in position. I repeat them 2 or 3 times. See, I make sure my X-ray machine is exactly the same position as set up beforehand. The picture I'm getting, in terms of what I'm seeing here, is the same on my X-ray my plan. Right? So if I want to correct it to that, I need to see the same picture. I do that maneuver. That maneuver. Then I uncover the anterior rim. Right? And then I'll make sure I've medialized the fragment. The teardrop comes up. Can you see the teardrop coming up? So yeah, I do that, then push, and what you do is you saw on Scott's picture, he puts a little clamp around here. A little clamp around there, you can do that. And on the set also you'll see the set in live surgery, he has a instrument like this, with a little ball spike on it, ball pusher, and I use that to push. So I'm struggling, I use that to push. Okay. The other thing you can do is you can take an osteotope here like this, and I do down here. So I should have on the outside. I should have the outside of the bone here. In that position, I should have the outside.